so welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, June the 11th. So thanks everyone for joining today. On the call with me from the STS side, we have myself and Emily Conrad, Banu Yatsi, Carol Crone, Nancy Honeycutt, and Ruth Raleigh, our GTSD clinical consultant. So thanks everyone for being on with me. In terms of our agenda, same as always, just have I have quite a few STS updates to share today, and then I'm going to turn things over to Ruth for our data manager education, and then as always, we're going to finish things up via Q&A. So if you could please submit your questions via the Q&A function and not the chat. It's just easier for us to keep track of where all the questions are. But again, we also have the raised hand function enabled, so feel free to raise your hand if you'd just rather ask your question. Just be sure that your microphone is unmuted and enabled on your end. All right, so let's go ahead and hop into our STS updates. So a reminder, the fall 25 harvest is currently underway, and that fall 25 harvest does include surgery dates of July 1, 2022 up through June 30th of 2025. Right now, the fall harvest is scheduled to close on September the 5th, and with the opt-out date, the last day to opt out is September the 9th. I also wanted to let you know that the GTSD Analysis Overview, there was a new version posted within the IQVIA platform. So just make sure that you have the current version of the Analysis Overview. The current version is dated May 28th of 2025. There's not a lot of updates from the previous version. There was nothing done analytically to any of the calculations or the way the data is calculated and reported out, but I had some additional clarifications. So the differences between the previous version and the current version is I just went in and updated all references where star ratings were mentioned. And then I added an additional clarification detail to the missing data participant level exclusion section. Oops, I missed a period there. Specifically, I added the dates to be included in the fall 25 analysis. So it's just a breakdown of the specific dates per each year that are included in each year for that section. So it included spring 25, but it did not include fall 25. So I just went in and added fall 25 as well. And the last thing that was updated for this current version is the esophagectomy exclusion criteria. I updated the verbiage in the second bullet point. Again, there were no changes to the current calculation. I just updated the verbiage to make it consistent with that same exclusion that's applied in the lung resection composite. So I just wanted to make the verbiage for that exclusion consistent between those two sections within the overview. So that is specifically, it's the patients with no induction therapy for same disease within 6 months who also have no evidence of primary tumor or missing pathological staging. So I just wanted to make the verbiage consistent between the two sections in the overview. Again, there were no changes to how that analysis is done. The June training manual is with our marketing team, and Grace has said it should be posted today. So hopefully she'll get that posted by the close of business today. So check the website. If you do not see it by the end of the day, it will be posted tomorrow morning. So Grace will get that updated on the website as soon as she can this afternoon. Sorry, the slide's a little busy, but we do have some enhancements to the GTSD dashboards. So specifically, on May 31st, we had some participant dashboard updates that were released into production. So if you have not noticed these, I just wanted to bring these to your attention. So again, this is for the GTSD Participant Dashboard, the non-analyzed dashboard. We added the conversion types to that reporting. We also added PLOS. We added the mean, median, 25th, and 75th percentiles. So that is now reported out in that discharge section for your participant dashboard. And then the last update that that was made for the participant dashboard, the procedures parameter, when you're going in to set your parameter, if you want to select long esophageal any of the other, we updated the very last choice. It was labeled as none, and we updated that label to now read all other procedures. So again, that's on the parameters page. When you're setting your parameters, you check the time, you select the time that you want to filter into, and then you select the procedures that you want to look at. So again, we just updated that none, that very last choice that previously said none, to now it reads all other procedures. We have another enhancement release this weekend. It's going to occur tomorrow night. So these new executive dashboard enhancements will be available to you, I think, after midnight Eastern Standard Time. So next week, if you are taking a look at the GTSD Executive Dashboard, you'll see the following enhancements to that dashboard. And I have some slides that I'll go through here right after I'm through reading through these, so you can see exactly what I'm talking about. So the first thing we've done, the airly greater than 5 days graph, we removed airly greater than 5 days from the graph for esophagectomies, as that really did not apply to esophagectomies. For the lung cancer resection bar graph, we added a drop down, so you can select. You can either look at all lung cancer resections, is what it's currently doing now, but after the release, you'll have a drop down where you can look at segmentectomies, pneumonectomies. You can look at individual procedures. We also added a new column to represent the 3-year rolling harvest timeframe. We added the N to the bar graphs. And then also we are displaying an asterisk when the harvest period includes a partial year. We also added a still in hospital metric to the current harvest missing summary. And then we've also added a new footnote to the composite quality rating summary widget. And I'll just give you visuals of these updates here in just a second. Also with this release this weekend, the GTSD risk adjusted report, there was an update to the lung cancer staging procedures graph. Specifically, the clinical staging procedures will now show all years of data. Currently, it does not include partial years. So you will see that updated with this weekend's release. So again, just when you go into the dashboard, you'll now see the airly graph is removed from the esophagectomy, so it's no longer being reported here. And then we have added the drop down for the lung cancer resection, so you can select all wedge resections, lobectomies, pneumonectomies, segmentectomies, or you can just look at the all of them together, as you currently can now. We did add a 3-year for my site, so you can compare your all 3 years combined to the STS 3 years. So we've added that as well. And then here is the N. When you hover over the graph or the bar, you'll see the N now included in that toolkit text. Also, the executive dashboard, the current harvest missing summary widget. At the bottom, you'll notice you can now get a quick glimpse of your number of cases still in hospital. So that's now on your current harvest missing unknown widget. Here we just added, again, like I said, the new text is just clarifying that effective with the spring 25 harvest, the star rating graphics were removed from the lung and esophageal composite measures, and moving forward, only the 3 category analytic descriptions will be displayed. So that footnote is going to be added here just for additional clarification. And then for the lung cancer staging procedures, again, you can see here this graph now represents the partial years when the report period includes those partial year timeframes. Okay. And then next we have a AQO update from Emily. So Emily, did you want to give our AQO update?
Everyone. The registration is now open on our website. So thank you for your patience in that, but it is up there. We also have our hotel information listed for the hotel block. This year, the general thoracic session will be on Thursday, and there will be a networking event directly after this session. So I thought I would mention that. If you're part of the Intermax database, that will be virtual only. It'll be on Tuesday, September 23rd. So we'll have a virtual event for that. We do not have a virtual event that is, live streamed, a Zoom event for general thoracic, adult, or congenital, because those will be in person in San Antonio. If you're part of the Intermax database, that will not be in San Antonio. So I just wanted to let you know about that, if that was a confusion for anyone. Um, Abstract submission closed. We had 20 total abstracts submitted, and we have some from general thoracic, which is awesome. So hopefully those will move on to poster presentations. The review is ongoing right now. What else could I mention? I think that's it. Oh, we've been planning the program. We're hoping to have that finalized by Friday, and then we'll be contacting our speakers on Monday, and it's looking great. We're going to be discussing a lot about the upcoming upgrade. A lot is going to be covered. It's going to be we're gonna have a lot of great speakers. I think it's jam-packed and it's gonna be really fun. So we
Yeah.
hope to see you there.
Yeah, so just to give you guys an idea of the current agenda, what we're looking at, we'll have our on-demand presentations. We're looking at having some presentations on our paraesophageal hernias, our thymus resections, tracheal resections, hopefully a research and then something on a presentation on audit for our on-demands. And then some of our in-person content, like Emily alluded to, we're going to be focusing on our 5.26 upgrade. So, that's going to be a lot of good and new information. So obviously we'll be going over lung and esophageal cancer, lung and esophageal sections. We're going to have Dr. Cedar, our GTSD workforce, is going to give us start the day off with a presentation. We're looking forward to that. We're going to go over like lung cancers, esophageal cancers, complications, nodes, trying to think some anatomy as well. So yeah, we've got a good agenda planned out. So we're looking forward to it. And hopefully you guys are able to come join us in person. We would love to have you in person, but if not, we understand. We would love to, join virtually. I think the only thing, Emily, is there a letter if data managers need recommendation for attending AQO?
Yes, that's on the AQO website. You click on the link that says request a justification letter, and then those will be generated within like 1 to 3 business days and sent to you.
Perfect. And we did have a couple questions about AQO. I figured we could probably just go ahead and tackle those while we're here. Does the in-person registration fee include Intermax virtual?
It does.
Okay. There you go, Sheila. And the pricing that Donna, all the pricing information is out on the STS website. The itinerary, the agenda hasn't been posted yet. We are still need the final sign off for the agenda by our workforce chairs. So that should be posted as soon as we get that final sign off and get that out there. So hopefully it should be posted.
We hope next week.
Yeah, next week. So absolutely. But yeah, so no problem. But yeah, again, and the pricing and everything is available out on the website at sts.org/AQO. All right, thank you, Emily. And if you guys have any other questions, feel free to put those into the Q&A and we can get those answered for you. So next, I'm going to turn things over to Ruth.
Thanks, Leanne. So we're going to start off with a little did you know question. So did you know that not all preoperative risk factors are rolled into risk adjustment currently? Not all lung resections for lung cancer are actually included in your site analysis. And that not all post-op events are considered major morbidities and accounted for in your star rating assessment. What do we call those now, Leanne? They're not called star ratings.
Quality ratings.
Quality ratings. They're not accounted for in your quality rating assignment. It's going to take me a long time, y'all. Okay, next slide.
Yeah.
So the analysis overview document I literally I could never do this job without you. Like I look at my analysis overview document and it brings tears to my eyes because it's such a beautiful document. So kudos to whoever writes that. It's incredibly helpful. I'm going to go to the next slide.
Yep.
The analysis overview document includes descriptions on how unique scenarios are managed. So what did we do with COVID patients? There were some COVID exclusions. Those dates are all outlined in the analysis overview document. How we've managed patients who have had a reoperation has changed over time. That's outlined in the analysis overview document. There is incredibly important information about missing data and participant level exclusion that is in the analysis overview document. It'll go into like what sequences are reviewed for missing data, what happens at the 2% threshold, et cetera. That's all outlined in analysis overview. There's an overview of risk-adjusted outcomes in there, so it'll tell you how to interpret your results, how your results are calculated, et cetera. Elise did a great talk on that at AQO last year. And I think we're going to cover that again this year a little bit as well. If you want to go to the next slide. The analysis overview document also includes the STS defined populations for lung cancer and esophageal cancer resections. Again, not every lung cancer resection for new lung cancer is included. There are other factors that go into which patients are rolled in. The same is true for esophageal cancer. Quality domains and study endpoints are defined. This is not an exhaustive list. This is just like a snip from the lung section. So you will know like airly greater than 5 days, for example, is not a study endpoint. It's a very important quality measure. I think it's one of the quality measures that my surgeons are very, very interested in always because it impacts length of stay and whether patients are going home with drains, et cetera, et cetera. So it's a very important measure, but it's not, it will not impact your, what is it called now, Leanne? You have to say it every time. Quality endpoint or whatever we call it.
Your quality rating, yeah.
Quality rating.
Composite quality rating.
I'm gonna get it tattooed on my left hand. Quality rating.
Composite quality rating, yeah. I know, it's hard. But
It's very hard.
It's gonna be a process.
The risk model variables, so what goes into assigning, like risk adjusting your patient population, all of that is also outlined in the analysis overview document. It's well, if you want to go to the next slide, I'll keep talking through this. So in short, you cannot excel in your role as a data manager without being familiar with the analysis overview document. It's in the IQVIA library. You can check it out today. You can reference it liberally. It's a short document. It's only 30 pages long, and it doesn't update monthly like the training manual. So if you wanted to print out the analysis overview document, it's not, I never recommend printing out the training manual, but you can print out the analysis overview document, particularly because you need to talk with your surgeons about it. It's really key to helping them understand their harvest reports. When they look at you and say, how can we perform better than expected? The answer to that question lies inside of the analysis overview document. They need to be documenting completely accurate preoperative risk factors, focusing on the risk factors that are part of the risk adjustment. And then they need to be aware of what the endpoints are so that they can take that into consideration when they're seeing whether they performed as expected, better than expected, or
Worse.
Needs improvement.
Yeah, we're sitting.
I swear I'm going to put in a poster on my wall. If you want to go to the next slide, please. So that's the end of my plea to each of you to read the analysis overview document. I did add to the training manual for June just 2 sentences in MTDC stat and MT the 2 discharge measures that talks about missingness and what happens if you're missing more than 2% of your data. But the analysis overview document is so much more comprehensive than anything that I could copy and paste and put into the training manual. Really, that's just a cue for you to go to the analysis overview and read everything that's in there so that you understand what will happen during harvest with your data. I'm not going to go into all of the June training manual updates. I just did want to highlight this one summary table that I added to Sequence 1880. Sequence 1880 talks about which lymph nodes, sort of the pre-question, the parent question to which lymph node stations have been sampled. There was, I thought, a great request from one of our data managers to sort of summarize like all of the different FAQs into a table as they pertain to lymph node assessment. So I tried to do that. It's a little bit challenging without too much text, but I thought we'd run through it quickly here. So lymph nodes that are removed prior to induction therapy are not counted in your total post-operative lymph node count that you provide in that section. So if you have a patient that has a mediastinoscopy, for example, they remove some lymph nodes, your patient then has immunotherapy, radiation, you're not going to count those lymph nodes in your total count at the end of your surgical resection. Lymph nodes are removed prior to the index operation, but after any induction therapy, or if induction therapy does not occur, would it be counted? These lymph nodes can be removed via VATS or mediastinoscopy. There are a plethora of terms for removal, which include but are not limited to lymph nodes being sampled, harvested, removed, or resected via VATS or mediastinoscopy. Lymph nodes that are biopsied via EBIS at any time are not ever counted. So the key difference there is that in VATS and mediastinoscopy, you're actually removing the entire lymph node. When the surgeon does the procedure, they can't go back and find that same lymph node again and take it out. When they do an EBIS, they're just sampling it. There's a little piece. When they do that's removed, they could remove that lymph node subsequently during surgery. So that's why there's a difference there in how those two are treated. Of course, lymph nodes removed during the index operation are counted. And then we do not count tissue that turns out not to be a lymph node on final pathology. So like your surgeon sends down a specimen labeled station 7, and the pathologist is like, so sorry, this is just some fat, there's no lymph node here. You would not indicate that you have a station 7 lymph node there. So hopefully this summary table helps. If you have suggestions for other places in the training manual where it would be helpful to add a summary table, I'm happy to do that. I think particularly as we roll into the next version upgrade, quite a few pieces of this version were preserved for the next version. And so I'll move to summary tables and clarifications so that we don't have to like redo all of this learning when we move to that next version. So let me know if you have any thoughts there. I'd appreciate it. Next slide. Something that I get a lot of questions about is the 4-month rule for clinical staging. So the only lung cancer sequence that requires clinical staging to be performed within 4 months in order to capture data for that sequence is sequence 1620, which is clinical staging methods. If clinical staging was performed, but all of it was performed more than 4 months ago, you would still code yes to sequence 1600 to indicate that clinical staging was indeed performed. You'll leave 1620 blank because nothing was performed in that 4-month window. Sequence 1630 is not going to open because 1620 is the parent to 1630. So you're not going to have to worry about answering any questions on mediastinal lymph node sampling methods. Sequence 1800, which is asking you for the largest tumor size in centimeters, can still be answered. You're going to use your CT if you have both a CT and a PET available to you. If you only have a PET, that's fine. You can use the largest tumor size from the PET. So I hope that helps clarify that some by just throwing it in a slide like this and having it available for reference in the future. Go to the next slide. And I wanted to provide a quick word on harvest codes. So there's a great call out by one of our data managers on this one as well. Harvest codes are numbers when you look in the training manual. So it'll say, like, for example, I think this is the clinical stage, lung cancer clinical stage sequence. So you can choose code 1, 2, 3, 4, 5. You have to pay attention because code 1 does not correspond to a clinical T1 tumor. 1 is TIS, 2 is T2, et cetera, et cetera. So the harvest codes are sort of standalone numerical values that don't correspond to anything clinically. The clinical information is listed in the value column. So hopefully that saves you all from some heartache going forward if that's confusing at all. I think that's the end of my slide.
Yeah, I can clarify a little bit in addition to this on the harvest codes. If you're not familiar, if you're, a site that use a vendor software, and so when your data file is extracted from your database and packaged up neatly and put into that DAT file to upload to IQVIA. So in that file, IQVIA doesn't receive the text like TIS or T1 or T2 or T3 or T4. We don't receive those values in the file itself. It's that numeric code is what is received. So we don't get the actual text values for what you're coding. We get the harvest codes. So I don't know if that helps make sense as well. So just a little additional info. Oh, it's Dion has a question. Hi, Dion. Hi, Dion.
Can you hear me?
Yes, ma'am.
Okay. So I understand that coding when it comes to like one may not correspond to grade 2, grade 3. So when I reached out to the pathologist in regards to that, she's saying that the CAP cancer protocol states that grade 4 is poorly differential. But we have grade 4 as unknown. So that's what was confusing for us. So you know how, like, if you're looking at and it might not be this exact one, but you know how we're looking at it and it might say well differentiated, poorly differentiated, whatever.
Yeah.
She's saying for CAP cancer protocol that the grade 3 is going to be poorly differentiated, not grade 4. But we have grade 4 in the manual as unknown. So if she just would have coded grade 4, I would have thought the histology grade would have just been unknown. And when it in actuality is poorly differentiated.
I'm just trying to pull it up, see what's in.
I think it's the same thing though, Deanne. Like I'm looking at the training, it's sequence 2080, Leanne.
2080, okay.
It's harvest code 4 equals unknown, not grade 4 equals unknown.
Right.
Okay.
Yeah. So it's just that's just the harvest code. It doesn't correspond to grade at all. It's just a number that is assigned to that text value. I don't know if that makes more sense.
Yeah, I see how that it corresponds to it, but if like the pathologist just put grade 4,
Yeah, they're gonna have to clarify for you
yeah,
what
you
text
have to
value that
clarify
is.
because automatically you're gonna think grade 4 as code 4 when it doesn't correspond. But we wouldn't know that according to the CAP protocol that it's grade 4 is actually poorly differentiated and not grade or code 3. You get what I'm saying? So you would automatically code it wrong. It wouldn't be audited wrong, but the coding would be wrong.
Well, I think it would also be audited as a mismatch because code 4 does not correspond to any clinical value. It's just a random number that was assigned.
Okay.
Yeah, Yeah, this is Paul. You want to be careful with that. The harvest codes truly are random numbers. They mean absolutely nothing. You don't want to associate, a number with the answer.
Yeah.
That's just a code that we get so that we're not getting all the big gobbly text that comes with the description. So yeah, you want to be very careful about that.
Okay. Thank you, guys.
Oh, yeah, no, thank you, Deanna. It's a very important question. Thank you.
A great question. Yeah, I appreciate it.
Yeah, absolutely. Sarah, Sarah, you had your hand up. I just wanted to grab these while I was seeing.
Sure.
Yeah.
Thank you. Can you hear me okay?
Yes, ma'am.
Just sharing, yeah, grade 4 is actually undifferentiated. So, because I'm a cancer registrar, I just want to share that. So I see how it can be confusing, but grade 3 is not poorly differentiated, like across, like for when we follow all grading. So I did look it up. So grade 4 is undifferentiated. So if you see on the path report, if it's grade 4, it would not be poorly differentiated. And I would question a pathologist on that, just to confirm it, but it's undifferentiated. Just to share that.
Thank you so much.
Welcome.
All right. Our next question, Ruth, from Anita. How do you size the lung nodule if it is GGO or partial solid?
There is a chart in the training manual.
Do you know what sequence that is? I can pull it over.
It should be, is it 1800? Let me see. Yes, 1800. Well,
Okay. Yep. Right here.
I guess the chart is not associated with 1800, but if you look at the text for 1800, so for purely ground glass nodules, there's like a June 2022. It's at the top of the FAQs for 1800 land, sorry.
Yep. Here.
So for purely ground glass nodules with no solid component, the tumor size is entered as 0. For mixed density with no documented size for the solid, you leave it blank. For mixed density lesions, you would enter the tumor size in centimeters for the solid portion only if you have that number. Hopefully that helps.
Okay. Anita, let us know if that helps. Is there a better procedure code name for evacuation of hemothorax, or do we just use other and enter the procedure?
Let me take a peek. Do you want, well, I'm looking at that. Do you want to
Yeah.
answer Stephanie's question?
Yeah, so where is this harvest code? I don't think I've seen it. So I think the harvest codes are included in the data specifications. I don't think I've never seen the vendor softwares, and Paul, please feel free to chime in. I don't think the vendors include the harvest codes in their
Yeah, and
interface.
actually, I can answer this one and the next
Yeah.
question from Mary. So that
Okay.
there is a good chance that you will never see the harvest codes unless you're looking at the data specifications.
Yeah.
What it is so when your vendor gives you the options, you might get a yes and a no. But what is being recorded in the database is a 1 and a 2. So that's the harvest code. And when the file, if you're using vendor software and you extract your data, it's full of a bunch of 1s and 2s, not yeses and nos. And that's what we get. Same thing for IQVIA. You don't see the code. You select the yes or no, and what goes into the database is the 1 or 2, whatever's appropriate for that for that code. So it's just a way that makes it, the files are much smaller, and it's a lot more clear than having the full text descriptions in the data files. So yeah, you might not see it at all. You'll just see it defined in the data specifications.
Perfect. Thanks, Paul.
Yep.
And the question from Mary, clarifying the harvest code for DDE, the value is abstracted, not the code. Yep.
Yeah, same thing.
Yep. All right, Ruth, did you find the answer for?
Yeah, I'll copy and paste it into the
Okay.
chat for Joseph. And hopefully it'll copy paste nicely for you. That's what I usually use.
Yeah.
evacuation of a hemothorax. Can everyone see the answers when I type them in the Q&A?
Let me see. It depends on all questions. I think so.
Okay.
Yep,
Please let us know.
they're showing up, the ones that you
showing up?
type in.
Yeah,
Mhm.
but you have to go to the answered section.
Oh, yeah,
Okay.
thanks.
Yeah.
Yeah.
Oh, cool. And then our next question, Ruth, any way to add not documented for ECOG? Often not documented within the year, then shows up as error.
There's not a way to add that for this version. We can
Right.
consider it for the next version. I think we talked about ECOG a lot. We've talked about ECOG so much for the next version that I don't remember where we even landed, but I will look at it again. Thank you for the feedback. We are aware this is a pain point. A lot of people are frustrated with that.
Yeah. So, and I guess, if it's not documented, then it would be imputed to the least possible risk.
Correct. So going back to the analysis overview document, this is where your surgeons really need to understand that if this is a lung or esophageal cancer patient, it will impact potentially their
The risk.
quality of reported outcomes and the risk that's because it impacts the risk assigned to performing surgery on that patient. But I know that it's a pain point for like non-cancer patients. There's very rarely an ECOG, and so it just gets frustrating pretty quick.
Yeah, I can't remember where we landed if we added not. Carol, do you remember off the top of your head? Did we add not documented? I can't remember. Like you said, I know we went back and forth.
Let me see if I can find it.
Yeah.
I can't even remember.
I
think
know
we
we went
added-
back.
There's so much discussion on it.
I think
Yeah.
we added ECOG score, yes, and then it opens the options, and then we added no, not a cancer patient, and then we
Oh,
added
yep.
no patient is a cancer patient, or like something
Mhm.
like that to try and
Yep.
make it so that for our cancer patients, we realize that we're missing that and it impacts risk adjusted outcomes, but there's also a way to say like, no, this patient doesn't have cancer, and that's why I don't have.
That's
any.
exactly what we did, Ruth.
That's it.
Yeah.
See,
So there's a no. No, wait, I'm sorry. There's a yes. You could fill it out. And then there's a no, patient is not a cancer patient and ECOG score is not available. And there's a no, patient is a cancer patient and ECOG score is not available.
yeah.
Right?
And speaking of the new version, like I said, we are, the form is very near finalized. We will be doing the same type of education like we did for the 521 upgrade. So if you weren't here for 521, if you're a newer data manager, prior to the go live, we held webinars and walked through each of the sections of the new form. As we had talked about earlier, this isn't considered like a major upgrade, but the biggest focus of this upgrade was to add variables that would help for, as Dr. Cedar has presented on and what he will continue to talk on at AQO, is long-term outcomes. So they're working on the long-term risk models and long-term, I think the calculators. So we added most of the new variables are dealing with predicting long-term outcomes for patients.
And didn't we rename, thanks, Leanne. And didn't we also rename this from ECOG to ECOG/Zubrod for the non-cancer cases?
We did.
Yep. So, Donna, the new version is scheduled to go live January 1, 2026. So we'll be getting stuff to the vendors here next month. And I said that with a smile on my face, Paul, and knowing you're probably blowing up my email right now. You and Carol and I
Just keep my head down.
you and Carol and I have a date planned. Denise has a question. Hernia types, my surgeons like to use moderate, small, large as descriptive terms, and they like to give a measurement. Did this change? My surgeon said they used to size them, and he will put a size. Hernia types.
I think you're asking if it used to be in 241. I think it did used to be in 241 that you could record a size, but it's been 3 years already and I don't exactly remember, but I can pull up 241 really quick. I think, hang on, I'm in the 241 training manual just a second. I think that we did used to collect hernia size. We did not bring that back for the next version. We were really focused, like Carol Leanne indicated, on the long-term outcomes for our cancer patients. So we didn't add it back, if that's what your surgeon was hoping for.
Let's see here.
Yeah, it used to be sequence 3050 hiatal hernia size in centimeters.
Also, if I know some people have sent me emails. I was out unexpectedly for, some of last week. So I am still trying to dig through my emails. I am slowly, I've been so many meetings this past week. So I'm trying to get through my emails. So if you're still waiting for a response from me, I apologize, but I am working through them as quickly as I can. And I wanted to bring this over as well. I know someone had asked about AQO and we gave the link, but if you're out on the STS website, I always just go to education if you want to find out about AQO, calendar of events, and just scroll down to advances in quality and outcomes, data managers meeting, and all of the AQO information. Minus, you can register now, book your housing. Here is the link to that requested justification letter that Emily had talked about. The schedule, as Emily stated, we will post the agenda as soon as we get that finalized. Should be available early next week, if not already available now. Information on virtual pass, our early bird pricing, standard pricing, and then hotel arrangements. And if you were an exhibitor, there's information there, but all of the information is out on the STS website. Okay, one more random question, Dion, of course. Do you know off the top of your head if the vitamin vaping FAQ is being reviewed with the core group? I know we have a core group called this Friday, Ruth, I believe.
It sure is on my core group list. That's a great question. And I'm not sure why anyone is vaping vitamins, but we did expand or change the way that we're collecting vaping for the next version. So I thought it was really important to understand what we wanted to do with that question now so that we can carry that over to the next version.
Yeah.
The collection of vaping information is not going away. So thank you for your patience. We are meeting on Friday and it is on my list.
That's interesting. That's interesting. Vaping vitamin. I've never heard of that. Interesting. All right. Any other questions from anyone? Feel free to raise your hand if you don't want to type it in. You're more than welcome to just raise your hand. We'd love to chat with you. But again, 5.26, again, the AQO is gonna touch a lot on what's coming up for 526. So again, we hope you can join us there. Again, justification letter is available. And if you have any questions about AQO, please feel free to reach out to us directly. All right, I'm not seeing any additional questions come in. So let's go through our next monthly webinars. So mark your calendar accordingly. Our next monthly webinars are scheduled for July 9th and August the 13th. Our quality improvement webinar for this month is going to be canceled. We have numerous people that are out of the office that week. So that's going to be canceled. And also we're going to resume with our next webinar on July 31st. And again, thank you to Kelly for her presentation on our last quality improvement webinar. It was absolutely amazing. And I think her slides and that presentation have been posted out on the STS website. So if you were not able to join, or if you haven't had a chance to go back and review that recording and her slides, I highly recommend going back and checking that out. Kelly did an amazing job on her presentation. So if you are interested in doing a similar presentation, for quality improvement, please reach out to us. We'd love to have you present. So you can share what your site is doing and share with your colleagues and how we can all help each other to help improve our patient outcomes. Beth has a question, Emily, regarding audit letters. They have not gone out yet, but I don't know, Emily, if you wanted to expand on that.
We're hoping to be able to send those out in July.
Awesome. Okie dokie. All right. Well, I don't see any other questions. So thanks everyone for joining today. I appreciate it. Ruth, thank you for your presentation. As always, my contact information is here. If you have any questions related to your harvest reports, the GTSD Executive Dashboards, the Participant Dashboards, please reach out to the help desk at stsdb_helpdesk@sts.org. Database operational questions regarding participation fees, contracts, things like that should go to stsdb@sts.org. And Kim, does the AQO Virtual Pass cover GTSD and ACSD, or is the price for each?
The virtual pass is for all content, so adult cardiac, congenital, general thoracic, intermax, and the general session on-demand content will all be on there. Yeah, it's everything.
Yeah, but again, yeah, no problem. But again, just a reminder, the virtual pass is not a live in-person streaming or a live streaming event. It's just all of our in-person content is recorded and then posted out to the platform, and you can go and review that content. But yeah, just a reminder, it's not a live stream.
Except for Intermax, which is
Except for-
only except for Intermax, which is
yeah,
only
exactly.
live streamed.
Yeah. So.
Thank you.
All right. Thanks, Emily. Thanks, everyone. Hope you guys have a great rest of your week. And again, please do not hesitate to reach out to me if you have questions. And for those of you that are waiting a response from me, I'm working through my emails, I promise. So thank you so much. I appreciate it, everyone. All right. I hope you guys have a great rest of your day. And we'll see you on July 9th for our next monthly webinar. Thanks, everyone.
Thanks, Lynn.
All right. Thanks, Paul.